As a physical therapist, you stand at the forefront of a patient's recovery journey following a cerebrovascular accident. Your role is not just to facilitate movement, restore function, restore confidence, restore independence. The period following a stroke is often filled with complexity and uncertainty for both the patient and the clinician. To navigate this, you require a systematic approach that is evidence-based and practical for a busy clinical environment. This essay provides such a system, designed specifically for you, the practicing physical therapist, to enhance your clinical decision-making and streamline interventions for common post-stroke impairments. The core goal is to move you efficiently from identifying a patient's primary problem to implementing a clear protocol, a repeatable protocol, an effective protocol. We will introduce the problem-to-protocol ladder. Not a rigid set of rules, but a flexible framework that simplifies the therapeutic process. It emphasizes starting with common functional deficits, applying a straightforward assessment, and linking that finding directly to a targeted intervention. This method maximizes your time for functional gain and ensures progress is consistently tracked. The problem-to-protocol ladder. It is a simple, 5-rung structure designed to organize your clinical thinking and action. It ensures your interventions are purposeful and linked to specific functional deficits. Rung 1. Problem identification. Rung 2. Focused assessment. Rung 3. Intervention protocol. Rung 4. Safety and red flags. Rung 5. Outcome measurement. Let us break down common post-stroke problems. Hemiparesis. Weakness on one side, impaired balance, higher fall risk, reduced confidence, gait deviations, slow, inefficient, unsafe walking, spasticity, abnormal muscle tightness, hemiplegic shoulder pain, a debilitating complication. A patient may present with all of these issues. The ladder encourages you to prioritize 1 or 2 problems per session. The power of this framework is its directness. For example, problem: weakness in the leg extensors preventing standing. Assessment: 5 times, sit-to-stand test. Protocol: practice sit-to-stand transfers with specific cues and assistance. Safety: use a gait belt and ensure a stable chair. Outcome: repeat the 5 times sit-to-stand weekly to track progress. This logical flow eliminates guesswork and focuses on functional improvement. It transforms a complex clinical picture into manageable, actionable steps. Using the ladder consistently enhances communication with the team and family. The problem is balance. We are measuring it with standing time. Our protocol is weight-shifting practice. We have seen a 10-second improvement this week. That clarity fosters collaboration and empowers the patient. The first and most common problem to address is hemiparesis, unilateral weakness that profoundly impacts daily tasks. Example: lifting an arm to comb hair. Example: extending a leg to stand. Your initial step is to define this weakness in functional terms. The focused assessment is simple and direct. Lower limb, the 5 times sit to stand. Time 5 stands without using the arms. Upper limb, a functional reach test in sitting. Reach to a table target and measure distance. Note movement quality and distance achieved. Once assessed, move to the intervention protocol. Key: task-specific, repetitive practice. For lower limb weakness, practice sit-to-stand transfers. Begin with 3 sets of 5 to 10 repetitions. Modify to ensure success. Use a higher chair. Modify: provide minimal assistance to initiate the movement. Progression: gradually lower the chair height. Progression: reduce assistance as strength improves. For the upper limb, if the problem is reaching, practice reaching. Set up repeated reach to grasp and move tasks. Reach for light objects, grasp light objects, move light objects. Dose: aim for at least 3 sets of 10 repetitions. Always use a gait belt during standing or transfer practice. Ensure the chair is stable and will not slide. Monitor for signs of fatigue, sudden spikes in blood pressure, or other vital sign changes, and increased pain. Key red flag: sharp pain during movement. Stop and reassess. Watch for overexertion such as excessive sweating or shortness of breath. If movement quality drops, take a rest break. Finally, the outcome measurement rung. The assessment tool often serves as the outcome measure. Retest 5x weekly and record time. Measure maximum reach distance or count object manipulations in 1 minute. Share results with the patient. For example, last week 45 seconds, this week 35 seconds, to demonstrate efficacy and keep engagement. Following weakness, poor balance is a primary contributor to fall risk and fear of movement in stroke survivors. The problem is an inability to maintain the center of mass over the base of support during static and dynamic activities. Your focused assessment should be quick and functional. A simple yet effective test is the 4-stage balance test. Hold 4 progressively challenging positions for 10 seconds each. Feet side by side. Semi-tandem, 1 foot slightly in front. Tandem, heel to toe. Single leg stance. Note which stage they can safely complete. This sets your baseline and starting point. If a patient can only manage feet side by side, begin there. Start with controlled weight shifts forward and backward, 3 sets of 10, then side to side, 3 sets of 10. Once confident, progress to dynamic challenges, reaching for objects just outside arm's length, or turning the head while standing to create a controlled wobble that drives adaptation. Safety is paramount. Train near a stable surface or parallel bars, stand close with a gait belt, and watch for dizziness, sudden uncontrolled sway, or fearful grabbing. If present, regress by reducing reach or allowing hand support. Re-administer the 4-stage balance test weekly. Progress is a longer hold or advancing to the next stance. For example, semi-tandem from 5 seconds to 10 seconds. Objective feedback reinforces effort and your plan. Difficulty with walking is one of the most significant functional losses after a stroke. Slow speed, asymmetry, foot drop, circumduction. Use the 10-meter walk test. Measure a 10-meter path. Time at comfortable speed. Calculate meters per second while observing toe clearance, step symmetry, and device reliance. This yields a number and a qualitative description. Intervention. Task-oriented gait practice with targeted cues. Do not overwhelm with multiple instructions. Pick 1 primary deviation per session. If foot drop, 10 minutes of walking with a single consistent verbal cue. Lift your toes, and a tactile cue tapping tibialis anterior just before swing. If asymmetrical step length, place small floor markers to guide foot placement. Cue, big step with your left leg. Use multiple short bouts of walking within the session for repetition. Safety is non-negotiable. Always use a gait belt. Position yourself on the weaker side, ready to support hip and knee, and ensure a clear path. Red flags include chest pain, severe shortness of breath, sharp increases in spasticity, and associative reactions. Outcome. The 10-meter walk test is your go-to metric. Retest weekly. Increased gait speed signals improved mobility and reduced fall risk. Also document qualitative gains, like consistent toe clearance and symmetrical steps. Case: Mrs. L. Baseline 0.4 ms. After 1 week of big step cueing, 0.5 ms, a meaningful and motivating change. The problem to protocol ladder is more than a tool. It is a mindset bringing structure, clarity, and efficacy to stroke rehabilitation. Start with a specific functional problem, apply a simple assessment, implement a focused intervention, and track a clear outcome measure, converting sessions into goal-driven science. Action. Choose 1 problem like poor balance. Use 1 assessment such as the 4-stage balance test. Link 1 protocol, progressive stance and weight shifting, and track it for 1 week.